Hello, everyone, and welcome to today's webinar, Diabetes Screening in High-Risk Populations, What Can We Do Better? I'm Cassie Soltman of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Abbott. To learn more, visit www.corelaboratory.abbott.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. Also, if you experience any technical issues, you can utilize this Q&A box and we will assist you directly. I'd like to now welcome our speaker, Dr. Mrinalini Kulkarni-Date, Chief of Division of Endocrinology, Associate Professor, Department of Internal Medicine and Medical Education, Dell Medical School at the University of Texas at Austin. Dr. Kulkarni-Date, you may now begin your presentation.
So I'm really excited to be talking about diabetes screening in high-risk populations and really focus on what can we do better. This is a disclaimer slide provided by Abbott. So today we're going to focus on a few things. I hope at the end of the presentation you will understand the criteria in type 2 diabetes and prediabetes. We'll identify patient populations that are high risk for diabetes and prediabetes. Spend some time focusing on what are the impacts of social determinants of health on diabetes, and also talk about the elements of successful screening and care programs. So let's first start by talking a little bit about type 2 diabetes in the United States. So we know that 38.4 million people have diabetes. That's 11.6% of the population. And of those, 29.7 million people have the diagnosis. They have a known diagnosis. However, that leaves about 8.7 million or 22.8% of adults with diabetes that is undiagnosed. So those are folks that don't know they have diabetes. We don't know that they have diabetes. They're not coming into the health center or something else is happening and they have not been diagnosed. Well, what about prediabetes in the United States? We know that there's an estimated 97.6 million people 18 years or older that have prediabetes. That's about 38% of the adult population. Of the 65 and older population, that is 27.2 million people, or 48.8% of those have prediabetes. And it's an astonishing 80% of Americans with prediabetes are unaware of their risk for type 2 diabetes. So they may know that they have prediabetes, but they really haven't been educated on what that means and why it's important to start intervention as soon as we know about that prediabetes diagnosis. Well, why is it important? So my residents are always making fun of me because I'm always telling them, you have this golden opportunity to identify patients with prediabetes in your clinic. We know that intensive lifestyle intervention prevents progression from prediabetes to diabetes. So what I'm showing here is the landmark DPP, Diabetes Prevention Program trial that looked at the effect of intensive lifestyle intervention on patients with prediabetes compared to metformin and placebo. And this was a very landmark, huge study because we suspected that telling people to eat well and exercise was a good thing, but this was really the first time that we had objective data that not only is it the right thing for people to be doing if they have prediabetes, but it really had made a significant impact. So those individuals that were engaged in the intensive lifestyle intervention, which consisted of dietary counseling, as well as 150 minutes of exercise per week, had a 58% decrease in diabetes incidence. And what's also remarkable is the study wasn't very long. It was about 3 years. And we saw a difference in that time. And then as we followed these individuals in the lifestyle intervention group, we see that there continues to be an effect from the time that they were in the study. So not only did it have an impact during the study, but that impact stayed with them for quite some time. That's tremendous. It's a tremendous effect of lifestyle on patients. These are some other lifestyle modification trial that showed similar effect. So what I want to point out, so there's the diabetes prevention program, which was done in the United States at multiple centers. Then you have one that was done in Finland and one that was done in China. And in all of them, you can see that the relative risk reduction was quite significant. And I always look at the number needed to treat. So you needed to instill lifestyle modification in 21 patients, for example, in the DPP trial, to have an effect in one person. So that's pretty remarkable. I mean, that is as good as some drug studies. So what do we have to do for diagnostic testing for prediabetes and diabetes? We can look at fasting plasma glucose, random plasma glucose, check hemoglobin A1C, or do a 2-hour plasma glucose after a 75-gram oral glucose tolerance test. And I'm going to show you now the cutoffs that are there. So for prediabetes, the criteria for fasting plasma glucose is a value between 100 and 125 milligrams per deciliter, or a 2-hour plasma glucose after oral glucose tolerance test of 140 to 199 milligrams per deciliter, or a hemoglobin A1C of 5.7 to 6.4%. This is based on the American Diabetes Association criteria for diagnosis. Well, what about diabetes? For diabetes, the fasting plasma glucose value needs to be greater than or equal to 126 milligrams per deciliter. The 2-hour plasma glucose level should be greater than 200 milligrams per deciliter after oral glucose tolerance test, or a hemoglobin A1C of greater than or equal to 6.5%, or the individual should have classic diabetes symptoms. So that's polyuria, polydipsia, blurred vision, plus a random plasma glucose of greater than or equal to 200 milligrams per deciliter. Well, who should we be screening for diabetes? We know what we need to do. Who should we be thinking about screening? So these are the criteria by the American Diabetes Association, as well as the American Association of Clinical Endocrinology, in who we should be screening for diabetes. And so there's quite a list here. So adults who are overweight or obese, people who have a family history of diabetes, particularly first-degree relatives, high risk race or ethnicity. So that would be Black, Latino, Asian American, Native American, and Pacific Islander. Anybody with a history of cardiovascular disease, hypertension, if they meet certain cholesterol parameters, women with a history of polycystic ovarian syndrome, physical inactivity. And I think that brings into a lot of people who might be physically inactive. Other conditions associated with insulin resistance, people with prediabetes, people with gestational diabetes. I think this is a really important we tend to miss. We are very good at taking care of women during their pregnancy, but we often see those women who have gestational diabetes get lost to follow-up, and those women need to come back. They need to get tested, and they need intervention if they continue to have diabetes or even prediabetes. Individuals with HIV exposure to high-risk medications or history of pancreatitis. And this last one is actually a recent change. So anybody else who is who is 35 or greater should be tested. It used to be just a few years ago that recommendation was age 45, but after some study and change, we know that this needed to change, and we needed to start screening earlier. So what did that do? So the changes in the criteria, particularly the age of screening, means that there is an additional 12 to 14 million adults in the United States who are eligible for glucose testing. That's quite a big number and somewhat overwhelming if you think about it from a clinician standpoint. This is a questionnaire that the American Diabetes Association has available on their website. You can download it, and it assesses your risk for type 2 diabetes based on your age, gender, if there was a history of gestational diabetes or family history, physical activity, and it also gives you the ability to stratify your weight category. So this is a great tool. The issue here is, who knows? People don't know where this is. They don't know that it exists, and they have to go looking for it on the website. This is something that we can easily have in clinics, in waiting rooms for people to be able to access. And then the question is, how do we make this available to individuals who are not in the clinic space and are in the community? So who are we not screening? We know we have this very large population of adults now that need screening. We're missing out on younger adults, age 18 to 44. Studies have shown that Hispanic adults are not getting screened adequately. We know education makes a difference. So particularly those without a high school diploma are not getting screened. And this perhaps is a function of not getting to a clinic site or an area of health screening. Those living in poverty are less likely to have a clinic to go to or a health center to go to. Those who lack health insurance also because they don't have access to care. And those who lack what we are calling a usual healthcare clinician. So they don't have a clinic or they don't have a clinician that they see on a regular basis. These are the individuals who we are missing in our screening efforts. And in terms of these high-risk populations that are hard to reach, they may interact. Why are they hard to reach? They may not interact with the health system very often. They lack healthcare coverage. They have low health literacy. They may not be aware that it's important to go in for health screenings. And this last one, I think, is really important. There is a lack of trust in the healthcare system for many individuals, particularly those in some of the high-risk race and ethnicity folks that are not getting screened and are hard to reach. So let's talk about social determinants of health and how social determinants affects diabetes and our screening efforts. So when you think of social determinants of health, what does that mean? Social determinants of health are conditions of the environment that people are born in, they live in, they work in, and these affect a wide range of health and quality of life outcomes, as well as health risks. And so they've been divided into 5 domains that you can see here on the right-hand side. And they include an individual's education access and quality, their economic stability. So certainly we see higher risk individuals are those who are at poverty levels, have much worse health outcomes. Social and community context. Are patients, are individuals isolated? What is their culture like? How does that affect what they might do in terms of health care and health screenings? What about the neighborhood and the built environment for individuals? Those we know now that absolutely affects individuals' ability to access and engage in healthcare. And what about healthcare access and quality? So some examples of social determinants might be, do individuals have safe housing? Do they have transportation? Maybe they don't have a vehicle to get to a clinic, and maybe there's no bus route that is close by for them to access, or maybe they have physical disability impairments that prevent them from using a standard bus. We also know that racism, discrimination, and violence in certain neighborhoods or areas of the community affect health outcomes. And then what about access to nutritious foods and physical activity opportunities? If you don't live in a safe neighborhood or you don't have sidewalks or parks, you may not be able to go out for a walk and engage in physical activity. So those are just a few examples of how social determinants may affect health. I want to go back now to the criteria, the screening criteria, and I've highlighted a couple here, and I've highlighted the ones that, really are most affected by social determinants. So, for example, this first one, in regards to adults who are overweight or obese, if you live in a community where you are having a hard time going outside, walking, don't have parks or sidewalks, you're not going to get out and walk. You're not going to get out and move. I think cultural and the community and cultural context plays a role here. If you are somebody who is socially isolated, don't have neighbors, don't have people around, you're less likely to engage in physical activity, for example. The high-risk race and ethnicity, definitely plays a role in who we are screening. So we know that, for example, the Black community has historically had trouble trusting the healthcare systems, and with good reason, given the history of not getting good care, and very understandable. We really have to make efforts to build up that trust, provide culturally appropriate resources for this population. And then I mentioned people with gestational diabetes because, again, often these are women who are in poverty, don't have great access to healthcare, certainly nowhere near where they're living, and after they have a child are very focused on caring for a newborn, and their own care goes to the wayside. So, and we don't really have good programming to get to these individuals. So again, social determinants really do affect several of these individuals that we need to be screening for prediabetes and diabetes. And I've just written those, shown those here in terms of specifically the social determinants of health that impact diabetes. I see many patients with diabetes in my clinic, but if they're dealing with housing security, food insecurity, poverty, not only does that create a lot of stress, and their focus is really on survival, they don't have time to engage in self-care, certainly don't have time to come to the clinic. So these are all things that definitely affect outcomes and even our ability to screen. So this slide is showing income and education disparities in adult health by life expectancy, health status, heart disease, and diabetes, stratified by poverty level and race and ethnicity here. So I want to I want you to get your attention to this graph on the lower right-hand corner that is looking at individuals with diabetes across different ethnic groups, and also looking at poverty level. So you can see that for all race and ethnicity, if they were at less than 100% federal poverty level, their percentage of diabetes in that group was higher than those who were at 300 to almost 400% federal poverty level. If you break this out by race and ethnicity, what you see is that at less than 100% federal poverty level, we had much higher percentages of diabetes in Black individuals and Mexican American individuals compared to white individuals who are at the same level of poverty. What's also interesting is if you look at those who were in the higher level of income in the black bars here, even at higher level of income, still 300 to almost 400% federal poverty level, Black individuals and Mexican individuals had a higher rate of diabetes compared to white individuals in that same bracket. So just to show that certain race and ethnicity are at higher risk of diabetes, even for the same, across the same poverty levels. and also that poverty does make a difference, does impact the risk of diabetes in individuals. This is another study that looked at predicted diabetes prevalence by race, poverty, and place category. And what place category is referring to is actually neighborhood. So you can see that if you are non-poor white in a non-poor neighborhood, you have a much lower probability of developing diabetes. Whereas if you look at poor Black individuals in a poor neighborhood had a higher predicted probability of developing diabetes. If you look within this, if you were a poor white in a poor neighborhood, you were similar, a little bit better, similar to poor Black in a poor neighborhood. And the other thing I wanted to point out is if for poor white in a non-poor neighborhood, just the neighborhood itself had an effect of the probability of having diabetes. So again, just another data point for us to see that neighborhood, poverty level, and race affect the prevalence of diabetes. So all of this to show and to say that as clinicians really need to assess and address social determinants of health. And this is really a new concept. So I still have colleagues who are like, look, I'm the physician or I'm the practitioner, and my job is to help people treat their diabetes. But the big point is, we're not going to make progress in treating diabetes. We're not going to make progress in screening for diabetes or pre-diabetes if we don't acknowledge the social determinants of health that are impacting patients' lives and even their ability to access healthcare and come see us in the clinic. We have to take more responsibility and have a greater awareness of these factors. So there are needs assessment tools to help us determine the social determinants of health that are affecting patients. The American Academy of Family Physicians, their Every One project has a validated social needs screening tool, as well as a toolkit that's available for physicians. And I've provided the link here for that. Also, the Robert Wood Johnson Foundation initiative was a multi-site national initiative that looked at social determinants of health. And there were 5 different institutions that developed their own screening tools, and these screening tools have been validated, and those are available for use as well. I should also point out that some of the screening tools that are out there and are validated are great, but you'll also see that some of them are done with a particular culture or community in mind. So it's nice to look at all of these and see which one might fit your community's particular needs. So let's talk a little bit about tailoring the intervention for the particular social context of the patients. So within communities, and every community is different, we need to be able to assess food insecurity, housing insecurity, who are patients that are being marginalized, what factors of structural racism are present. And we need to be able to identify those and refer them to appropriate community resources. Well, I can refer, but I really need to look at the community and make sure that those resources are there in the first place. So thinking about assessing what is in your community, what do your patients need? And every community may have different needs, and we need to be able to recognize that. It's also important to enable patients to be able to manage their own disease and manage their own health by providing health coaches, navigators, or community health workers. I work with community health workers, and I have to say that they are probably one of the most important people on my team. They are really able to engage with patients in a much more significant way than often I am, and on a deeper level, and it does make quite a difference for many of my patients. And Also, we really need to consider using community health workers for diabetes management, particularly in underserved communities and healthcare systems. What are the challenges beyond what I've talked about for screening and diabetes prevention? Well, we've mentioned that it's difficult to connect high-risk individuals to adequate, accessible, and affordable diabetes prevention and care services. We also don't have any national quality metrics focused on diabetes or pre-diabetes screening. There are no benchmarks. There are studies that have shown variable screening rates across health centers, and not only across health centers, but also across who's doing the screening. Is it a nurse who's doing the screening? Is it a physician doing the screening? There are various levels of pickup there. We don't have any single stakeholder responsible for offering services. So this isn't a governmental responsibility per se. If you have health insurance, what is your health insurance doing to make sure that services are being provided? We have gaps in testing. We're not doing well with educating patients of their health risks. Communication and referral by clinicians is also inadequate and better in some places than others. And we also are limiting what we are doing in terms of seeing our patients adhering. Are they adhering to care plans? Are they engaging in care plans? How can we get better at that? And we have insufficient infrastructure to facilitate this. So we need to facilitate lifestyle change for 96 million individuals with prediabetes. That is a huge number and really daunting. So we need to have a population health focused intervention on how to reach these individuals. We also need to provide clinical care for 37.3 million people with diabetes, including those that don't have access or not engaged with clinics or health centers. One of the best ways we think to do that is Wegner's chronic care model. So hopefully you've seen this before. So the idea with the chronic care model is that in order to have productive interactions and improved outcomes, the health system or healthcare organization needs to have these 4 areas developed at the level of practice. So self-management support, delivery system design, decision support, and clinical information systems. And I'm going to talk about those a little bit more in a second. And also we have to engage the community. So you'll see that here self-management support is in the health system, but also in the community. We have to have more resources for our patients to engage in self-management support in the community without having to come into the clinic. So that encompasses both areas. If we have this integrated system, our goal would be to have an informed, activated patient, a proactive and prepared practice team, and that we deliver healthcare in a better way and enable for improved outcomes. So how do we do this? Well, the team is really important to this delivery system design. You need to have, it's not just having a clinician, you need to have a multidisciplinary team of individuals. That means having nurses, registered dietitians, pharmacists, psychological support. I've had a health coach in my clinic before. Social work is absolutely important to help connect my patients to funding and resources in the community that they can access. And we need a team working with primary care clinicians that are supported by specialists. And patient education needs to be a part of this delivery system, coaching, and continued monitoring and care coordination. And again, community health workers, these individuals are key to engaging patients outside of the health system. And that's actually a very effective place to engage our patients. What about self-management support? So you might hear of this as diabetes education or pre-diabetes education. We're now calling it self-management support. And this is the shift from, just having somebody come in and educating them, but educating them in a way to empower them into taking care of themselves. What are things that patients can do for themselves, keeping in mind their individual goals? What is it that their goal is in their life? And I really find that that's a powerful way to motivate patients. We don't always understand what individuals' goals are, and it's really important for us to do that. And then facilitate management via the diabetes prevention program. Diabetes prevention program, based off of the trial that I mentioned earlier, is a significant program with good efficacy, with shown efficacy, but it's very interesting that that program is still not well hardwired into most communities. Still a lot of issues with availability, and also a lot of issues with engagement by individuals. And then problem solving and goal setting with patients is also very important in self-management support. Decision support. So these are tools and techniques to improve the decisions that we're making about patient care. They might include flow sheets. They're maybe hardwired into the electronic medical records. They might have care algorithms. These are really important because if you think about our clinicians and our teams, who are being asked to do more with fewer resources, decision support tools can be great reminders and can really help facilitate appropriate care for everybody. What about clinical information systems? So, we use EMRs, and EMRs have been cited as causes of burnout for many clinicians. But if we can implement practice overviews within our EMRs, decision-making tools within our information systems, including remote patient monitoring and telemedicine in areas where healthcare is difficult to access. Those are all ways that we can improve engagement. This is just, it's maybe a little bit hard to see, but this is a screenshot of what a dashboard might look like. So this one is for hypertension. It has the individual's hypertension values over time. It actually has listed up here the individual social determinants of health. So there's been a screening done, and these are the ones that have been identified, and also provides some recommendation and treatment plans. And here also is really helpful. It calculates the cardiovascular risk score. So who are the people that have a higher risk that you really need to make sure you help with blood pressure control. So these are ideas. This is just an example of dashboards that can be implemented that can be helpful in managing a patient population. Well, what about the community? Tapping into community resources is really a key part of this care. That might involve peer-led self-management support groups. It often involves church groups or community centers. We work closely with several churches in the area to help with patients who need just integration into the community. They may be socially isolated. They have prediabetes or diabetes. So our community health workers help involve them in church groups or community centers where they can find programming for physical activity or education. And then the larger health systems. We need to promote preventative care more. We need to appropriately allocate resources. Our traditional healthcare system is really, really focused on treating acute problems. And that's how billing works. That's where all the the coding comes in. That's what's emphasized. And we really need to figure incentives for health systems as well as caregivers to achieve preventative milestones in prevention. I want to talk now a little bit more about community-based screening programs. So this specifically community-based, culturally tailored education programs. So this is, there was a systematic review that looked at studies 74 studies for various health issues. 48 of them were targeted to diabetes. And they looked at these studies that were done where care was being given outside of the clinic. So we had churches, faith-based centers, community centers. There have been several studies about engaging the Black community, specifically Black male community at barbershops. You may be familiar with this one or have at least heard of it, and also home visits. And these programs must be delivered in appropriate language and cultural context, and individualized to address social determinants of health and culture. And understanding that this is a dynamic that's experienced differently by different people, being aware of that. So it's not a one-size-fits-all solution. And these have all involved community members and leaders. So pastors, counselors, peer leaders, trained community health workers, and having this sort of community-based tailored education program showed better outcomes, improved diabetes knowledge and literacy, self-efficacy, and self-management. How this was measured obviously was different in the different studies, but overall seemed to improve knowledge and literacy, which I think is very important for our patients to be able to be empowered in their own health management. Here's another example of a community-based program. So this is a mobile diabetes education program. This was actually a program from Solano County, California, that had a mobile trailer that was staffed with certified diabetes educator specialists. They had a bilingual diabetes program coordinator. There were also medical students that engaged community members and local residents. They visited several metropolitan areas and networked with many organizations and developed a set of partners. These were community centers, food banks, Salvation Army, senior housing facilities, public schools, and churches. And it's really interesting when you read the study and you talk to the folks who were involved. This was a learning process for them. So they set out starting to do one thing, and as they learned a little bit more about the culture of the communities that they were visiting, the community suggested to them, you should try X rather than do Y. It'll be taken up better by the community. So this intervention, they did health screenings, they had an intake questionnaire, they did finger stick blood glucose testing and point of care hemoglobin A1C testing, and education in multiple languages. 55% of the participants were at an at-risk group for diabetes or prediabetes. Over 5 years, they did over 12,000 visits. 1/6 of their patients had prediabetes. And of the 380 hemoglobin A1Cs that they did, 44% were in the prediabetes range and 51% were in the diabetes range who hadn't necessarily engaged in care prior to that. So again, another community-based where they're actually going out in the community, learning from the community how to best engage with individuals who might be at risk. This is just one of their screening handouts that they gave patients. So there's this algorithm where patients were asked if they'd been diagnosed with diabetes, if they had been seen by anybody before, and if they hadn't, there were some follow-up questions. And based on the answers of this questionnaire, they were given the option of getting a point-of-care glucose test, and some of them also met criteria for hemoglobin A1C. And they were given the option, they were given this recommendation, and so these handouts were given in the community, and many of them then sought the mobile trailer to come and get tested. So these are just some examples, but what are the elements of a successful diabetes or prediabetes screening program? We need data-driven clinical decision support to automate risk assessment, because we have a huge population to care for, and we need to be able to automate some of this to be able to effectively penetrate the population. We need to have scalable approaches to screening. So I like to think of it this way. We need the right information to the right people in the right format through the right channels at the right time. We need to be able to get to people in places that are convenient for them. So catching them at the right time and getting them the right information is key. We need to leverage remote or point of care screening, and team-based care is just indispensable in this model with an emphasis on nursing and community health workers. And we need community-based programs that are culturally appropriate. We need to be able to think about the community that we're interested in, or our own communities that we work in, and think about education and screening that's appropriate for that community, and to allow for community trust and buy-in. So hopefully you got some new insights about diabetes and prediabetes screening. So just in conclusion, we know that we have a large number of individuals that need diabetes and prediabetes screening. We know that the current rates of screening across clinics and communities are variable, and we are in particular missing the high-risk populations who have a higher risk of prediabetes and diabetes. I hope I've conveyed that it's very important to consider social determinants of health and impact in diabetes and prediabetes prevalence, and in designing effective screening programs. And we believe that the chronic care model is important. The pillars of the chronic care model are essential to be able to implement, particularly team-based care, to developing scalable data-driven models. And then community screening interventions are really important, including community-based tailored education that engage community members and leaders are important for effective community trust and engagement. And I can't say more about how important community trust and engagement is going to be if we're going to be successful in improving our screening of individuals in the community. With that, I'm happy to take any questions.
Thank you, Dr. Kulkarni-Date, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. Let's go ahead and get started. Our first question asks, what are the risks of delaying a type 2 diabetes diagnosis, and could you comment on other screening you recommend for diabetic or pre-diabetic patients for their heart and kidney?
Okay, so the risk of delaying a diagnosis of diabetes or even prediabetes is that, we have a higher risk of uncontrolled glucose, which leads to complications or diabetic complications, such as retinopathy or, bleeding in the eye, kidney disease, and certainly what we call neuropathy, which is when diabetes affects the nerves. Most commonly, patients will have numbness or tingling or burning in their hands or feet. And over time, that nerve damage can lead to ulcers that aren't healing, circulation gets impaired, gets affected, and the final stage would be amputation. So we certainly want to detect early so we can have diabetes better controlled. The other important note, I think, here that sort of goes along with our presentation is we know that some of the higher risk race and ethnicities some of them, those groups also have a higher risk of developing complications. So all the more, need for detecting early. In terms of other screenings, anybody with type 2 diabetes should have a urine microalbumin to creatinine ratio test done to detect for albuminuria. That's an early sign of kidney disease. We should, also look at hypertension and cholesterol values in these individuals, because patients with diabetes do have twice the risk of atherosclerotic cardiovascular disease. So those are really important to do. The American Diabetes Association really has a nice description of all of the screenings that should be done in patients with type 2 diabetes in their clinical practice guidelines. And they actually have an app that you can download and look those up.
Excellent. Thank you. All right, moving along here. Our next question asks, if prediabetes is detected, should one recommend lifestyle changes or medication?
Great question. So in talking about the diabetes prevention program that I presented earlier in the slideshow, absolutely we should encourage lifestyle intervention. That is first line if we can get patients to engage. Now, there are patients who are going to be less amenable to lifestyle intervention. It may be something they're not able to do or don't want to do. And if we're not able to get engagement in the lifestyle intervention, then I do think metformin is an option. For example, that was also in the study showed some benefit in terms of prolonging a type 2 diabetes diagnosis. It's not a formal recommendation at this point. In other words, we don't say, oh, you must start metformin, but I think it is an option for those who are not able to or don't want to engage in lifestyle intervention.
Okay, great. Thank you. Our next question here says, should teens or young adults be screened for type 2 diabetes?
Great question. I do think based on the screening criteria, we will find that we have absolutely young adults, but we will also find that some teens need to be screened, particularly if they meet the overweight or obese criteria and have family history, a heavy family history as well.
Okay, so we have time for a couple more questions here, so I'll just keep moving on here. Our next question asks, how can we encourage follow-up testing and treatments for patients that are rural or in healthcare deserts?
That's a great question. Certainly, we know that this is a problem, and it's a very large problem. This is where community-based programs come into play. We need to engage the community resources. We need to think about community health workers, engaging with the leaders of the community and creating programs that might enable better screening. I think, the mobile, having mobile access, maybe it's the mobile van trailer that we talked about in the presentation is an option. But I also think we are going to see more and more digital health. So remote patient management, for example, being able to connect to patients remotely for follow-up care, looking at results of screening, or even just screening is going to be key. And I do think you're going to see that become more common.
Wonderful, thank you. And we have time for just one more question. That question asks, what is the role of digital health or remote patient management in DM screening programs?
So this is kind of, pairs with the last question. I do think digital health is going to be of significant importance, as do I think AI is going to be of significant importance in developing scalable and, cost and thinking about cost. So cost manageable programs for screening patients. Particularly rural areas, but also in urban areas as well, target and being able to get to people who don't regularly interact with the healthcare system.
Wonderful. Thank you for your time today and your important research. We would also like to thank LabRoots and our sponsor, Abbott, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions that we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.